Okay, this slideshow is going to focus on hearing aid orientation groups. So this entire week we've really been focused on hearing aids and testing. Well, we've already talked about diagnostic testing, particularly if we're focused on hearing aids. We've talked a great deal about hearing aids verification measures like functional gain and speech mapping, insertion gain, so looking to verify or if we're meeting target for our patients based on the hearing aid fit. We've also talked about self-assessment scales, right? So subjective, which would be self-assessment evaluations of how their own assessment of how they're doing with hearing aids, or pre and post hearing aids. And as I said, objective measures like functional gain or using test protocols, test protocols such as functional gain or insertion gain or real ear measurements, speech mapping. And so speech mapping and insertion gain would fall under the category of real ear or in situ measurements in the place of. So we're actually measuring the amount of gain of the hearing aid across the frequencies to different presentation levels. So we can, remember we talked about the carrot story. So a man is talking on and on about growing carrots, and we can present that at a level of soft speech and see how they do. Are they hearing it? Is it audible through their hearing aids? Because remember, the equipment based on the audiogram that you enter into the computer is setting targets within the long-term average speech spectrum. So we want to make sure that soft sound, so if we present the carrot story at a soft volume, is it audible? Then we present the carrot story again. So we may present first at 50 dB and then again at 65 dB or 70 dB, and then we're going to also present sound at a loud level to make sure it doesn't exceed their uncomfortable listening levels. And we talked about using these as tools to motivate and encourage our patients to stick with hearing aids, to make changes, maybe if we're not at the optimal settings and we can make changes. And we also talked about what those changes entail, programming, so hearing aid programming. And to kind of take it another step further, what is really amazing is we can fit our patient and run the verification measurement. So we can do speech mapping, so they're listening to the carrot story, but while the hearing aids are, we can also at the same time have the hearing aids connected wirelessly to another computer and make programming changes in real time. So I can make changes to the hearing aids so that as the carrot story is running, we're hitting closer to target. And we can all do that in real time. So it's very impressive, and hopefully it's a great counseling tool for many different purposes, to counsel our families, their significant others, friends, caregivers who can come along to encourage the use of hearing aids. Sometimes it's to try to decide between two different types of hearing aids. Oftentimes an individual will want the completely in the canal hearing aids, thinking it's for cosmetic purposes. Maybe they're less noticeable. But because of the extent of the loss, we may want something that has more power. So we, as audiologists, we might want to fit a receiver in the canal hearing aid or a behind the ear hearing aid. So sometimes we can do those comparative measures where we fit them with completely in the canal hearing aids, but they're saying it's not loud enough, and then we're showing them the difference between different hearing aids. We can also counsel based on older hearing aids or older type technology versus newer technology if we're trying to show the benefit. Okay, if somebody says, overall I don't really know what the benefit is, I don't know if I'm doing very well, again we can show that. So lots of different reasons. So in this set of slides, which will be the last ones really based on hearing aids, is one more component of how we utilize hearing aids as part of the rehabilitative process, both for our pediatric patients or our adult patients. But again, we'll talk specifically about our pediatric population towards the end of the quarter. So the first slide you're looking at, there's a quote from Dr. James Jerker, who is very well known in the profession of audiology as a researcher, as a teacher, as a clinician, but his statement is hearing aids are the cornerstone of auditory rehabilitation. And we think that we can all know from the information up to this point why that would be. I would agree. Hopefully you may agree with that statement. Because our first step is we have to make sound audible. Oftentimes an individual may have a mild loss or a borderline normal hearing sensitivity, and we might not say, yes, you need hearing aids at this time. We might say that we need to monitor their hearing once a year or sooner should concerns arise. We might want to talk to them about communication strategies, and we're going to be talking those as a part of rehab through the rest of the quarter. So we might not always fit hearing aids, but we know when there's a when there is enough hearing loss where they're candidates for hearing aids, that is our first goal, that it's the cornerstone, because we have to make sound audible to be able to move on from there. So this set of slides is going to focus on hearing aid orientation in groups. So I want to make sure to clarify, up to this point, I've really been talking more one-on-one, patient-clinician. Right? We've been talking about the testing procedure. We've gone through tests. We've gone through modifying tests. We've reviewed audiograms. We're talking about hearing aid fittings. And that typically is going to be one-on-one with the patient, the audiologist, and family members, of course. But there's another rehabilitation option called hearing aid orientation groups. And that's what this slide is showing. It's where some of this information is taken, so acknowledgments for that site. So for hearing aid orientation, we know we have our initial fit. Now, some individuals might be familiar with hearing aids. Maybe they've worn hearing aids for quite a while, but they're broken. They could potentially not be worth repairing anymore. They need to change technology. They maybe have a more significant hearing loss, so they need more power, they want Bluetooth options. So they may already be familiar with hearing aids, or it could be somebody who was a caregiver for someone with hearing aids, their spouse already wears hearing aids, so they might be familiar. But typically, in the initial fitting process, we really make the assumption that the individual has no background or no knowledge of amplification, of all the features of the hearing aids, the batteries, use, care of them. So we can do, in the initial fit, we do one-on-one, or we can also have group sessions. So we're going to talk about what that's made up. Brief review and so this is a note to myself. Do a brief review and introductory comments about adults or seniors and hearing aid manipulation. Remember, we've talked about sometimes we make choices of different hearing aids based on the patient's vision capabilities. Can they see the components, and can they manipulate them? So sometimes with adults, particularly seniors, we can begin to have arthritis. Sometimes the tips of the fingers lose sensitivity, so there can be manipulation issues of the hearing aids. So we need to work to find solutions, whether it's just ongoing practice or a larger hearing aid, or sometimes we can order hearing aids so that the features are raised. So just to give you an example, on this in-the-ear hearing aid, where my cursor is pointing is the program button. Sometimes we can have some of these external controls and we can have them raised so that perhaps this will stick out even further, so that it's easier to feel. Okay, so we need to work with our patients about hearing aid manipulation. Another option also is a remote control. When these first came out, everybody wanted remote controls. What remote controls can do, of course, you can use the remote to turn your hearing aids up louder or softer, and you can switch between programs. So for example, if you have a specific telephone program or FM program or music program, and the buttons are fairly large so that you can see those or feel them. The problems with remotes, though, is they tend to get lost right? They tend to get lost. It's another battery to be concerned about. They tend to break. But we still fit these when there is vision issues or dexterity, or so problems with manipulation. So with adults versus pediatrics, there is quite a bit more in the process of adjustment to make sure they feel comfortable manipulating, putting the hearing aid in, taking the hearing aid out, opening and closing the battery door, replacing the battery, to make sure they're comfortable. And there tends to be a lot of anxiety that goes along with this topic because these are very expensive instruments. So let's say you're sitting down with a patient that's purchasing hearing aids for $3,000 each, and they're worried, well, if I grab it by this wire, am I going to break it? If it's not in all the way, it's going to fall out, I'm going to lose it, I'm going to be out. So a lot of stress. And this comes up also manipulation issues and anxiety with parents when we're fitting newborns, babies with hearing aids. You know, how can we hold the baby still? How far do I push it in the ear? Is it fitting? If it's not in, will we lose it? Will the baby reach up and grab a hold of it, put it in their mouth, or swallow the battery? So these are all part of the process of orientation. So typically, as an audiologist, as I said, we do the initial fit in a one-on-one orientation, and of course we always encourage them to bring family members, a caregiver, their adult children, because a second set of eyes and ears is always good because of that nervousness. Because often when you sit down with your patient at the initial fit and say, all right, this is exciting, today's the day we're going to fit our hearing aids, most of our patients are thinking, what are they going to feel like? What are they going to feel like? What are they going to look like? Are they going to hurt? Are they going to be noticeable? Will they itch? Will my ears feel hot? They're concerned about the cost. So oftentimes they don't catch all the details that we're talking about throughout the orientation. So they might miss things and get home and think, oh, what did she say? How do I do this again? So it's always good to have a second set of eyes and ears. Although printed information is essential to give to our patient. So typically in the first fit we give cases, cleaning tools, batteries to last a while, printed information, and we do want to have that printed information available in various languages, which it is, and to know that ahead of the time. Oftentimes we have patients who are non-English speaking individuals and they come with a translator, but when they go home we want that information printed in their own language. All right, so the goal, so we're really going to talk about, let me back up a little bit. When we talk about a hearing aid orientation, we talk about one-on-one, but we can also do group hearing aid orientation. And I'll talk about how we would set up that scenario, right? Because how could we say, well, wait a second, we're fitting a whole bunch of adults at one time? No, it's a little different. So our typical first fit, of course, is going to be one-on-one because we're fitting the hearing aids, we're making sure they fit okay, we're putting we're setting the programming for the hearing aids. Okay, but before I talk about the different scenarios, we want to talk about the goal. And this is really the goal in oral rehab, regardless of what we're doing, regardless if we're just giving diagnostic information to our patients and making recommendations, regardless if we're doing a hearing aid fitting, regardless if we're discussing communication strategies, where they should place themselves in a busy restaurant, regardless if we're doing some lip reading or speech reading, practicing skills with our patient. We're really working towards the same goal. And the goal, as you see on this slide, is increasing patient self-efficacy. Okay, so the first thing I wanted to do is define self-efficacy. So self-efficacy is the confidence a person has in completing a set of skills requisite for success in achieving a particular goal. So completing a set of skills that are needed for success to achieve a particular goal. So in hearing aid orientation, we need to give our patient that set of skills, understanding how the hearing aid works, being able to manipulate how the battery works, those kinds of things, so that they feel comfortable and can move on to be successful with the goal. I want to back up because I thought this was an interesting study as far as perspective of what an individual wants out of hearing aids. There was a 2002 study that found that younger adults are mainly focused on their hearing aids, helping them to hear speech in noise. So that was the focus of younger adults, and honestly I don't know the cutoff ages from this study, but younger adults were more interested in their hearing aids functioning in background noise, where older adults or elderly patients most value speech recognition in quiet situations first, followed by their next priority was understanding in noisy environments, and then their next priority is ease of manipulation. So that was kind of the focus. Although we have to be cautious not to stereotype. I have known individuals in their 80s and 90s who are more active and are in more challenging listening environments, meaning more places with background noise, than individuals who are in their 60s and 70s. I can say in Portland, I have fit a woman with hearing aids who is 100 and one who is 103, and both of those women are continue to be very active with family and friends and in lots of different environments. So while that study showed the difference in focus between younger adults and elderly or seniors, we still need to look at each individual and not stereotype. Okay, so back to self-efficacy. So self-efficacy is the confidence a person has in completing a set of skills requisite for success in achieving a particular goal. It's essential to incorporate the following principles in the hearing aid delivery. Okay, it's essential to incorporate the following principles into hearing aid delivery, or the hearing aid fitting. We want to go from simple to more difficult tasks, okay, which would be so that we don't overwhelm them, again, because of the anxiety. And one thing that I want to note right here before even the first one is, remember in kind of the protocol, we see our patient, we test our patient, we give them results, we give them options, they may make a choice with hearing aids, or choose hearing aids. We may talk about those choices, we might take ear mold impressions and order, okay? Then we may say, all right, we're going to schedule you in 2 weeks for your hearing aid fit and orientation. It's these 2 weeks right here that I want to put in an extra dot. That is very important to give them something during those 2 weeks. Printed information to review, general information about hearing aids, how they work, batteries, maybe some websites to look at, so that when they come back, they already are somewhat educated. Not that you don't want to do your job, but it kind of lessens the anxiety a little bit, and then they're more savvy about what you're going to be discussing. But again, we want to start from simple to more difficult tasks. And in hearing aid orientation, that could be from, okay, let me show you how you tell your right hearing aid from your left hearing aid. Right? And I, just so that you know, either the shell or the ear mold, the right one has a red marking on it and the left one has a blue. We want to do extensive practice, right? So typically we have an hour and a half set for this time, and I want to make sure, without making the patient feel uncomfortable, to practice taking the battery in and out several times until they seem to be comfortable, to practice taking their hearing aids in and out, and to not make them uncomfortable, we might do it once and then move on to another topic and then come back to it and do it again and move on to another topic, those kinds of things. Because it can be very stressful. Especially if they're having they have some dexterity issues. I had a gentleman who had terrible arthritis in his shoulders and really had difficulty reaching up high enough to place the behind the ear hearing aid over his ear, but was set on not having his caretaker do it. So we'd practice the time and then we kind of rest and talk about something else and go back to it. We also want to suggest practicing at home. Engaging in role play, that's a suggestion, but I don't really use that technique very often. Setting clear and specific goals, and so that's really important, so that we say to the patient, within the first couple days, why don't you just use your hearing aids for a few hours at a time? So let's start slowly in quieter environments and then increase over time. Now, of course, this isn't necessary for all patients. Sometimes patients will put them in their ears, they walk out, they wear them all day long, they take them out when they go to bed. They don't need to build up that time. But the reason we do set specific goals, especially for the length of time wearing them, is if they have a significant hearing loss and haven't heard those sounds in many years, it can be very overwhelming and very tiring, fatiguing, so sometimes kind of building up to it. If the person is anxious, if they're anxious about loud sounds, we also don't want to have them have a negative experience right off the bat. It's a little easier to build up. So for example, they're going home, they're watching TV, they're interacting with family members in the house versus going to Costco and running, and then running errands and then going to a loud place for dinner. So maybe starting easy and then work on clear and specific goals. Then I want to get back to the concept of self-efficacy again. I have a few more notes on that I want to discuss. So again, that's confidence to make so that the patient will be successful. And this doesn't apply again just to hearing aids or communication strategies that we're going to talk about. I mean, we can make this applicable really to anything we do, or working on certain goals with patients in speech language pathology. So if patients have high self-efficacy towards amplification, they're more likely to keep and use their hearing aids rather than only use them at certain times, put them in a drawer, or return them. So, okay, I see where my notes were leading. Some notes on simple to difficult tasks. I want to add a few more things that I'm seeing now that I wanted to discuss. So starting with simple skills and progressing to more difficult tasks. Another point is seniors or elderly may need more time processing this information. So we might need to review it slower. We may need to go over it a couple times. They might also have more questions. We also want, as I said, we want friends, caregivers, family members to be active learners and to ask questions and be part of the process. We also want to periodically make sure our patients are understanding, so some demonstration that they're understanding instead of just kind of being passive and nodding their head. Okay. They also, I'm sorry, I keep going back to the same thing. They also may need some additional information. So aside from the instructions, sometimes printed simple instructions of how to care for them need to go back to a care facility for nursing staff. So we might need some more step-by-step instructions. I know that I have been working with one elderly woman who she'll come in and she'll tell me, these aren't loud enough. I want you to crank them up all the way. And I'll say, well, let's turn them up a little bit louder. And I'll turn them up quite a bit. And she'll say, this is great. And the next week she'll come back frustrated and angry with me that the hearing aids are too loud. So let's turn them down and let's make, now I want a program button. Okay, I don't think she should have a program button, but we add it. And then next week she comes back and she's angry. They're too soft and I don't want the program. So I think that there's some frustration and possibly some cognitive issues. So what has helped in that scenario is every week writing out what we did at our appointment and what our goals are until we see each other. That way we can kind of see the flow of what we've done or what she's wanted, and then it takes some of it's actually been taking some of the frustration out of the mix. So we may want to give them additional information. We can, when we talk about extensive practice, we can often also have them practice again at a follow-up. Sometimes this happens where I'll have somebody come in at a follow-up appointment and part of their ear is sore. And I'll see it's because they don't have their ear mold in all the way. So it's kind of tweaked at a funny angle, putting pressure on the ear that shouldn't be there. So again, a time to just do more practicing. Okay. Hold on a second. Okay, these are a little bit out of order. So that's pretty, what we've been talking about is pretty much a one-on-one hearing aid, first fit hearing aid orientation. But what I want to introduce and explain to you is the concept of a hearing aid orientation group. This may be composed of new and or experienced hearing aid users. So oftentimes, we used to do this years ago at the Hearing and Speech Institute. One of the adult audiologists did a wonderful job at this, where she would look at all the patients that she had fit with perhaps a 4-month time period and offer to them a free hearing aid orientation group where they would meet a set amount of times to practice or ask questions or to review anything that they were having difficulty with. So again, it may be composed of new, they've never been fit with hearing aids, or experienced hearing aid users. These are people who maybe are trying different technology for the first time. Significant others, family members, caregivers are encouraged to attend. Sessions are geared toward promoting successful use of amplification. So we're gonna, as we work towards the final project, we're gonna talk about what our oral rehabilitation sessions are composed of, right? The 4 different sessions that you're gonna be looking at. This is a little bit different. This would be sessions geared mostly towards hearing aid orientation. But, and I want to make sure you're aware of this, you could incorporate hearing aids, how hearing aids work, or depending on the population that you're inviting to your group, hearing aid orientation could be part of it. But typically, again, this is something that works really well with private practitioners. So for example, if I was an audiologist who owned my own private practice and I was hopefully fitting, possibly 20 individuals a month or more, I would invite all of those new fits over a certain time period to come into these orientation groups. Now, you would think most of the time by 4 months they are comfortable, but that's not always the case. And as we're going to see as we discuss group orientation, oftentimes individuals, particularly the senior population, like this repeat, this reinforcement of information. One of the benefits is they can interact with each other so that one person says, well, this works for me, but this doesn't work for me, didn't work. It's the feeling that other people are having the same concerns. I remember thinking about this with moms groups. If any of you have kids, I kind of thought the whole idea of moms groups was kind of corny when I had a kid, until I went to one. And then I would see other mothers doing, or they had a product that I thought, well, what's that? And they, oh yeah, I tried this, but this didn't work. Or, oh, when mine won't go to sleep, this is what works. So just other people experiencing similar issues, problems, anxieties, to talk about things. Oh, well, what worked for you? Well, this worked for me. Other people who are going through the same thing. Just that in and of itself can be so helpful and so supportive. Okay, let's talk about the last point on this slide. An HAO stands for hearing aid orientation. Hearing aid orientation groups were first introduced when servicemen returning home from World War II with significant hearing loss, and that's the site I found this from, at that this was the group of individuals. At that time, veterans were first fit with hearing aids and then sat through classes as long as 8 hours a day for 8 weeks on topics such as hearing aid orientation, communication strategies, and lip reading. So this was when this idea was first came into play. And we're going to talk about a little bit. What we haven't talked about is really the history of AR, and we're going to get into that in next week's slides. So let's go back still to self-efficacy. Another term that I want to introduce is androgy. That's why I spelled it out phonetically. I still can't say it. Androgy. The method or techniques used to teach adults. Okay, so again, we're focusing on adults. We're not talking about a pediatric population here, but we will, and you can work with young adult population for your project. I don't want to get into our AR too much specifically for a young pediatric population, because that's really more focused towards the parents or caregivers. But as you see in the direction, you can do like high school age or high school transitioning out of high school to college or the workforce, or young adults. But this is the methods or techniques used to teach adults versus teaching children. So there's a different emphasis. The emphasis, adults are self-directed, and we expect adults to take responsibility for their decisions. Adults need to know why they need to learn something, right? When we teach at the elementary school level, you teach them and they say, okay. But as kids get older, they say, well, why do we need to learn this? Adults need to learn experientially, so through experience. How can we apply this practically? Adults approach learning as problem solving, right? How do I resolve this? How do I fix it? They utilize critical thinking. Adults learn best when the topic is of immediate value, right? So if I was here in front of you, or we were all together, I would ask you if this applies to how you learn in college, right? You have to be self-directed. You have to take responsibility for your decisions. If you decide not to view the lectures and want to open the exam, well, we have to take responsibility for that. We want to learn why. We want to know why we need to learn this. How is this important? We need to learn through experience. Could I really see this in play? If you were observing an audiologist and you had an opportunity to sit in on adult oral rehabilitative classes, I think that then it would be even a more valuable opportunity, and maybe some of you will. Adults approach learning as problem solving. So I'm sure you do. How do we resolve this problem? And it's best learned when you can see the immediate value of it. So this is kind of the method or techniques that we want to apply when we work with adults, whether it's in group hearing aid orientation or with groups or participants at ongoing oral rehab sessions. So let's say you establish a program with 4 sessions like you will for your final project. I want to talk about, when we talk about principles of learning, so if we're looking at having a hearing aid orientation group or an adult oral rehabilitation group, let's say in a senior center, we need to focus on the 5 principles of learning of how adults learn. How will we direct this material to this population? Okay, so how will we, sorry about that. Okay, so we want to apply these principles, what I just talked about on the previous slide, and what I'm going to talk about in a diagram, that these are the principles for adult learning. So again, we're focused on adult oral rehab in this setting, not pediatric. You do not have this diagram in front of you, and if you go to this site, it actually will have the list of the things that I'm talking about, not so much a diagram. But let's talk about that. So if you have this site in front of you, it goes through and you'll see the list and it'll be the same thing that we talked about. The diagram is actually from a textbook where it has 5 circles around and 1 circle in the center. The center circle says ARweek adult learning theory. The circle at the very top, and you'll see that in the list in this website, is self-concept promotes self-direction. So what this means is, as we apply it to hearing aids, would be, okay, the top circle is self-concept promotes self-direction. Effective hearing aid orientation groups do not consist of didactic teaching. Didactic teaching is this, me lecturing to you, right? That's didactic teaching. So effective hearing aid groups, or an oral rehab group, excuse me, do not consist of didactic teaching or just someone in front lecturing, but should be highly interactive and directed by the participants' needs. And we're going to talk about that further when we talk about examples of how to structure your 4 seminars. So let me give you an example. When I did these with the graduate students in Arizona, the graduate students at the first meetings, let's say we'd have 6 AR sessions, so it was advertised, and we'd come in and maybe 15 people and their significant others were there. They would design a survey asking a little bit about them, have they ever worn hearing aids? Do they have hearing loss? Are they here with somebody with hearing loss? So some basic information, but the most important is, what would you like out of this experience, right? Or out of the 10 topics, please rate your level of interest, 1 being the most interested, 10 being the least. Okay, so we want the sessions, whether it's hearing aid orientation group or just general oral rehab sessions, to be directed by the participants' needs. So that fulfills the self-concept, promotes self-direction. We want it to be self-directed. The second principle in adult learning is experience is used as a tool. So our participants learn vicariously from each other's experience in working with hearing aids or amplification. And we kind of said that. I've already said that, where they can see what works and what doesn't. Somebody will say, oh, I was really having difficulty on my cell phone, but my audiologist fit me with this Bluetooth technology and it made a huge difference. So they can learn from each other, especially when others in the group are supportive of their frustrations and offer other suggestions. But also, those who are frustrated have an opportunity to observe other successes. Okay, so in this, again, this principle is experience is a tool. Participants learn vicariously from each other's experience. Number 3 is I'm having trouble seeing that. Orientation is for immediate application. So adult learning is oriented for immediate application, right? You're going to learn, a concept's going to stick with you if you can turn around and apply it, right? If I teach you something today and then later this afternoon you can apply it in a clinical environment, it'll stick. So for the third principle, adult learning is oriented for immediate application, consisting of information and skills that hearing aid users can apply now to improve communication. So an example of this one, I think a great example we'll be talking about soon, would be communication strategies. Right? So for example, one that I keep bringing up would be how to position yourself in a restaurant. And these are such basic things that oftentimes people don't think about. If they go at the height of the dinner hour, it's going to be more crowded and more difficult to hear. If they go to a place that's poorly lit because it's the environment and it's more romantic versus a brighter lit area, sitting under a speaker with music is a poorer listening environment, right? A worse signal to noise ratio versus a quieter room. So what if we work, and this is a suggestion, something that you could do in a session would be to give an individual homework and say, these are the 3 areas that I want you to work on, and have an example to discuss next time, right? So an adult will learn and absorb the concepts if they can apply it immediately. All right, let's go to the 4th one. The 4th one is readiness is for fulfillment of, sorry, I'm having trouble seeing that, fulfillment of roles. So the 4th principle, adults are eager to learn what is important in the fulfillment of roles in their day-to-day activities. So for example, as a member of their community organization, as a communicative spouse, as a bridge partner when they maybe meet for bridge or for golfing. So what this principle is saying is an adult learner, adults are eager to learn what is important to, let's say not in, but to the fulfillment of their role, right? And so what we are often working on in either a hearing aid orientation group or a general oral rehab group is better communication. The oral rehab groups that we put on in Arizona, in every session we ever ran, could see frustration between spouses, okay? Because one individual can't hear and is ignoring the other one and is frustrated and keeps asking her to repeat, and so we have this breakdown. But what this principle is saying, adults are eager to learn because they want to fulfill their role. So again, of being better communicative partners. The 5th one is adult learners are internally motivated to learn information and skills that are relevant to their personal goals, right? So if I have a group of individuals who are in to do a hearing aid orientation, but I spend the entire time talking about how to program cochlear implants, they may say, well, okay, that was kind of interesting, or maybe it was interesting for 10 minutes, but over the whole hour, it's not relevant to what I'm here for, right? So it has to be, they're internally motivated to move forward if it's relevant, okay? Okay. So I think that it's very important to use these principles of adult learning as we structure, whether your sessions include a hearing aid orientation component, depending on the population you're going to target. And again, I think I'll spend one lecture talking just about the final project as we learn more and more information. But or if you design for sessions that are related to speech reading, communication strategies, being an active listener, we need to apply these principles so that they're relevant and interesting and motivating to our adult learners or our adult participants. So let's just give kind of an example. If we're doing a hearing aid orientation, a group orientation, or okay, let's say that, a group orientation. This is just an example. So for class 1, our overall goal, and for your final project, you are going to have to state your goals, right? So your overall goal of what you want to accomplish in each session. So class 1, your overall goal to inform regarding insertion, care, operations, gradual adjustment a gradual adjustment schedule, getting used to your hearing aid, and to acquaint with practical use of the phone. And then here's a whole list. We could administer a self-assessment scale, review hearing components, review insertion and removal, review care and cleaning, maintenance, review characteristics of batteries, hierarchy of listening experiences and steps in hearing aid use, review a list of listening strategies with amplification, practice telephone use, and a reminder of day and time for next class and topics to be discussed. That's a lot of information. If we're talking about working with seniors, you would easily have 2 hours of information, which is probably too much for them to absorb. But a lot of this would be refresher, even if they've worn hearing aids before, or they've just got new hearing aids, and some of it they might be familiar with, or say, you know, I thought the audiologist said that, but I forgot about that. It's good to see again. Okay? Now, of course, we're thinking if you're a college age student, if you're a young adult, if you're, you know, in your career, no, this would be too slow of a pace. But our seniors, elderly population who are, let's see, 65 and older are going to be the majority of individuals wearing hearing aids. They do like this repetition and this ongoing support. And then this would be an idea for a class too, a second class. So a hearing aid orientation group is just really a little bit different than what you'll be setting up for your oral rehabilitation sessions. So the hearing aid orientation group isn't just going to talk about hearing aids, it's going to talk about a lot of other things. So here we can see, if I look down the objectives, introduce importance of visual cues, introduce speech leading, review listening attentiveness activities. Okay, here's an example of a class 3, and I posted these for you so you can look through these and pull some of the things that particularly interest you to implement in the 4 sessions that you're going to put together. So you can go through this list. Oh, this is also a hearing aid refresher curriculum. The audiologist who did this at Hearing and Speech would annually offer a refresher class. So just 1 session for the same people to meet. And the goal, I'll read you the goal, overall goal, to offer patients who have used hearing instruments in the past and accompanying persons a review insertion, care operation, use of telephone, visual cues, listening strategies, basically a general review. And often individuals like to say, what else is out there? What other things could help me? What assistive listening devices? What Bluetooth technology? So this is an option too. I think that all this is interesting, and I hope that most of you are finding this surprising, that these are things that audiologists do, right? That audiologists are involved in therapy, right? This is the therapeutic process. This is the rehabilitation process. We don't just sit in sound booths, quiet sound booths, and turn dials and push buttons and ask people to raise their hand. So we have this ongoing relationship with individuals. So hopefully this is also giving you some ideas about your final project. We're going to be talking more and more now that we've kind of got past the entire range of hearing aids, assistive devices. We talked about hearing aids, we talked about assistive devices, we've even touched on bone-anchored hearing aids and cochlear implants. So now, weeks 4 through 8, we can now talk about the different components. Once we fit hearing aids, or even without, we can offer what we can offer additionally in oral rehabilitation. So as we go through these, again, I'll be bringing up things related to the final project, which is why it's very important to listen to the lecture so that you don't miss that. But I think in the next coming weeks, I'll do a slideshow specific to the final project so that we kind of also know the expectations and it's starting to gel a little bit. All right, so this concludes lecture 4 of week 3.